Hello and welcome to another live broadcast with MedStar Health. I'm Michelle Carter. February is Heart Health Month, and it's never been a more important time to discuss the topic of heart failure, a progressive and life-threatening disease. Of the more than 6.5 million American adults living with heart failure, about 10% have advanced heart failure. Today, we're joined by a few of our advanced heart failure cardiologists. We have Dr. Sandeep Jani, Dr. Richa Gupta, and Dr. Farouk Sheikh. It's critically important for patients, caregivers, and anyone interested in heart health to understand the risk factors, symptoms, and treatment options that are available for heart failure and advanced heart failure. So share this broadcast with your friends and give us a like to let us know that you're watching, and keep tuning in to learn more. Before we get started, I'd like to just introduce our speakers again. I'll ask you briefly to share what you do here at MedStar Health. I'll start with Dr. Sheikh.
Thank you so much. Good afternoon to everyone. My name is Farouk Sheikh. I'm the medical director of the heart failure program in the DC region.
Thank you. Dr. Johnny.
Hi, everybody. I'm Sandeep Jani. I'm the medical director of the heart failure program in the Baltimore region.
Thank you. Dr. Gupta.
Hi, I'm Richa Gupta. I'm one of the advanced heart failure doctors up in the DC region.
All right. Thank you all for joining. Let's get a bit of background. I'll turn to Dr. Sheikh for my first question. What does heart failure mean?
Thank you for the question. In the simplest sense, heart failure is the incapacity of the heart to perform the essential function, which is to pump blood adequately to all the vital organs. It's manifested in symptoms in no particular order, such as shortness of breath, fatigue, inability to perform the normal activities of one's daily life, swelling, particularly in the legs and the abdomen. But in its simplest sense, is just the incapacity of the heart to perform the normal functions of the body, which really relate to the adequacy of the pumping of the blood throughout the body.
Okay. And can you explain ejection fraction and the role that it plays in heart failure?
Yeah, very important question. So you heard in the introductory comments that nearly 7 million Americans have heart failure. Broadly speaking, heart failure can be distributed into two groups. One, those with a reduced ejection fraction, where the pumping function of the heart is reduced, and then those with a preserved ejection fraction. This is actually a mathematical equation. It's just the difference in blood volume within the pumping chamber of the heart, classically the left ventricle, at the end of relaxation, which we call end diastole, minus the end of contraction, end systole, divided by the end diastolic volume. You don't have to remember that, except that that percentage is not 100%. Roughly normal is 55 to 65% of the blood within the heart in that pumping chamber leaves the heart with each heartbeat. And so often, and I think that second part of the question and what role it plays is important, because some of our academic knowledge and clinical trial data is defined as to which drugs will improve the outcome for patients, their survival, their quality of life, their functional capacity, on the basis of the ejection fraction. So it matters, it is important. And there are different outcomes for patients in regard to that can be defined by their ejection fraction. But that being said, I think it has actually simplified the field too much, because so often patients say, well, I'm so short of breath, but my ejection fraction's fine. Why is that the case? And we need to remember that 50% of all patients with heart failure have a preserved ejection fraction. The problem is that the relaxation of the heart, for various reasons, either a primary reason or secondarily to some other process within the heart, such as a valvular abnormality or an infiltrative cardiomyopathy, makes the heart incapacitated to do its function. And so that's why this is an important measure, but not the end all be all.
Okay. Thank you very much for explaining that. What causes heart failure, and what are the most common risk factors for heart failure?
Yeah, we could spend the hour going through this, and any one of us could answer this question. I won't do that. There are hundreds of causes. Broadly defined, they can be related to a muscular problem, meaning issues with the muscle of the heart. Remember, there are 4 chambers within the heart. The lower chambers, known as ventricles, pump blood on the right side. The right ventricle pumps blood to the lungs to reoxygenate the blood. And then the left ventricle, which has received oxygenated blood, pumps blood to the body through the major artery of the body known as the aorta. And so there can be a primary issue with one or both of these lower chambers, but there can also be problems with the valves of the heart, meaning there are four valves within the heart. Think of them as doors separating four rooms within a building or a house. Those can be primary issues. Now, if we go even more broadly, there can be diseases within the body that where the heart is an innocent bystander and the heart is injured because of that process. Diseases such as rheumatologic illnesses, lupus, rheumatoid arthritis, conditions like sarcoidosis. And then we're not even yet discussing the possibility and the existence of genetic causes of cardiomyopathy. So in total, hundreds of causes, and this is where the work of your clinicians is essential to figure out what the cause is. Now, risk factors are really important because the risk factors define, if we said 7 million Americans have heart failure, then there's tens, maybe even 100 million Americans who are at risk for heart failure. And our goal is to prevent the disease. Hopefully you don't have to meet us. If we control your blood pressure, we control your diabetes, we prevent the development of coronary artery disease, blockages within the arteries of your heart. We encourage you to live a healthy lifestyle with regular exercise, abstinence or limitations of alcohol intake and other risk factors. So there are, I think the most common, in the United States, I would say the most common risk factor remains hypertension, which is obviously highly treatable and requires engagement with your primary care, family medicine doctor, your APP. And then smoking is another risk factor, which unfortunately puts us at great risk, remains still a major issue in the United States in regard to the development of atherosclerotic vascular disease, otherwise known as coronary artery disease as it relates to the heart. Those are the major risk factors that I would focus on today.
Thank you very much for sharing, Dr. Sheikh. Turning over to Dr. Johnny now, can you share some of the warning signs or symptoms of heart failure?
Yeah, happy to. The tricky part about heart failure symptoms is that it can overlap with many other disease processes. So just having these symptoms doesn't necessarily mean that you have heart failure, but some of the common symptoms are shortness of breath. And in my experience, people tend to recognize this as a very abnormal shortness of breath, or a worsening shortness of breath. Like last year, I could walk around a mall and now I can't walk around the grocery store, that kind of stuff. But people tend to recognize it as being something wrong. Swelling of the legs or sometimes of the stomach happens commonly. And one of the body's reactions to heart failure, not just heart failure, but other disease processes as well, is that the body retains extra fluid that in the past the body would have just gotten rid of through the kidneys and urinated out. So swelling is common. Inability to lay flat, particularly on someone's back, meaning they get short of breath when you lay flat. That's generally a sign of having too much fluid, but it can be a sign of other issues like valve disease and other things as well. Waking up at night, gasping for air. That's a common symptom that some people have, particularly when they have too much fluid on board. Chest discomfort is not a direct sign or symptom of heart failure, but can be suggestive of other cardiac processes that lead to heart failure. And lack of appetite, or eating and just getting filled up very quickly where you can't finish a normal meal. These are all very common sort of symptoms that we see day in and day out in heart failure patients.
Okay, thank you. Could you now share the different stages of heart failure and how quickly can they progress?
Yeah, there are a couple of different staging systems that we use day to day. The first is a staging system that was created by the American Heart Association and American College of Cardiology. And these are stages A, B, C, and D. So A are people at risk for heart failure. So these are some of the risk factors that Dr. Sheikh was talking about, like people with hypertension and diabetes and obesity and smokers, but they don't have heart failure. Stage B are people who have like anatomic or physiologic changes in their heart, but don't manifest any of the symptoms. So those would be people who happen to get an echocardiogram, an ultrasound of the heart where the heart is weak or the heart is thick or the heart is abnormal in some way. but don't retain any of the fluid, aren't short of breath, and don't have any symptoms. Stage C is the bulk of heart failure patients, and these are patients who have structural changes to their heart and have symptoms and are on medications that I think we'll talk about later to help treat those signs and symptoms. And then stage D are the 10% that you referred to earlier, in which the heart is simply not pumping enough blood to the body, and the medications are no longer kind of doing the job they need to do. And that's where we start thinking about the advanced heart failure options that we're going to talk about in a little while. The second staging system is New York Heart Association, and this is more about symptoms. And it goes from 1 to 4. Stage 1 is no symptoms at all. Stage 2 is symptoms such as shortness of breath on very heavy exertion, like running or something like that. Stage 3 are symptoms on regular activity, just as like walking. And stage 4 is symptoms when at rest. So this is short of breath, just sitting. And that's the NYHA class that you'll sometimes see referred in the notes in the way we talk about things.
Thank you. And are there any differences between genders in terms of the risk factors or prevalence of heart failure?
Yeah, so there's several. The risk factors, such as hypertension and diabetes and smoking, and those obviously occur in both genders. And the difference is they seem to be a little more impactful in women. They seem to create a higher risk of developing heart failure in women than compared to men, though they create risk in men as well. In terms of, there are specific risk factors that are, specific to women or higher incidence in women, such as autoimmune disease that was referred to earlier, peripartum, meaning around the time of childbirth, some people can develop heart failure. That's obviously more specific to women. Chemotherapy, especially for patients who have like breast cancer, which is obviously much more common in women, can cause risk for heart failure as well. And then in terms of prevalence, heart failure tends to be more common as everyone gets older. But as people get older, it seems to be more common in women compared to men, especially in the heart failure with preserved ejection fraction, the heart failure with strong hearts sort of paradigm. That seems to be more common in women as we all get older.
That's very good to know. In terms of how it shows up among, between men and women, let's talk a little bit more about that. Do women tend to develop heart failure at the same age as men? Does it happen earlier, later? And what about the warning signs? Does it show up differently in men versus women?
That's a good question. I think the first thing to say is I think people can develop heart failure at any age, though it becomes more common as people get older. And I think women in general tend to develop it a little older than men. Symptoms tend to be similar in shortness of breath and leg swelling. I think the chest discomfort part of things is less common in women than men. And I do think that, unfortunately, some of these symptoms tend to get overlooked a little more commonly in women compared to men.
Thank you very much. One other term that you mentioned was peripartum cardiomyopathy. I hope I pronounced that right. So Dr. Johnny, could you explain what that is, how it can impact heart failure? Just elaborate a little bit on what you shared before.
Sure. So peripartum means around the time of pregnancy. And so peripartum cardiomyopathy is medically defined as heart failure that develops during pregnancy or within the first 6 months after childbirth. And that's just sort of the consensus definition that people have agreed on. So it can present in the same sort of way with shortness of breath and leg swelling. And these things are sometimes hard to tease out because some of these things happen in just pregnancy in general. And it's obviously specific to women. So sometimes it can be very mild and recover, and sometimes it can be more severe. Luckily, overall, I think it's fairly uncommon, thankfully, so we don't see it a ton, but it is certainly something we look out for and treat aggressively when we find it.
Thank you very much. Now I'd like to turn to Dr. Gupta to talk a little bit more about the differences of how heart failure shows up in women. From a physiologic perspective, what are some of those differences in women that may increase our chances for heart failure?
Sure, I'm happy to take that question. So Dr. Johnny touched on some of those. Physiologically, of course, the hormones are different between men and women. And also as part of that, the risk factors have different implications. The same risk factors that Dr. Sheikh and Dr. Johnny just kind of went over can manifest differently in men versus women. Peripartum cardiomyopathy is a good example of that, where changes in hormones actually can influence the vascular biology of women and their cardiovascular system and predispose them to developing heart failure. In both men and women, there's also there can be a genetic component to that as well, too. And then your other question was kind of how this might manifest differently in women. I think symptoms in women are also a little bit more subtle compared to those in men, which may be why women are not as diagnosed as frequently as men are with having a heart issue or having heart failure. And as a result of that, the symptoms might be a little bit different too.
Okay. And then one other question, when does heart failure become advanced heart failure? What does it mean when it's labeled advanced?
Sure. So switching the topic a little bit. So, the way that I kind of like to explain that the concept of advanced heart failure to patients is, the natural history of heart failure is that it can progress and get worse with time. So we have, really good medications and good devices like biventricular pacemakers that can help stabilize heart function for some time, and that stabilization can occur for years. But despite those things, heart failure can still progress, kind of similar to how cancer can progress. I think the two diseases are similar in terms of long-term trajectory in many ways. In advanced heart failure, the medications have stopped working to stabilize heart function, and the heart function's gotten worse to the point that the heart can't keep up with the demands of the body. It's not able to, adequately supply the circulation of blood needed to keep all organ systems working well and happy, to prevent fluid from building up, and to prevent the symptoms of heart failure, shortness of breath with exertion, exercise intolerance, trouble breathing at nighttime, those kinds of things.
Thanks, Dr. Gupta. And then also for you, how is the progression diagnosed? What are the signs that the heart failure is progressing? And what's the sign that people should talk to their cardiologist or their doctor?
Yeah, there's no one sign, but I can give you a sense of, just some of the things to look for. And progression can sometimes happen slowly. If a patient has had heart failure for a long time, they may not feel too much change week to week, month to month, if it's something that they've been dealing with their entire life. In other cases, it may be very quick, where all of a sudden they're dealing with extra fluid and worse shortness of breath or new heart issues like arrhythmia. Those are all kind of some warning signs that the heart failure may be advancing. Some of the signs that we look at whenever we're treating any of our patients is whether our patients who have heart failure are tolerating their medications well. So the usual kind of heart failure medications that we use to stabilize the heart function, things like Entresto, losartan, metoprolol, spironolactone, Jardiance. Those are just some of the heart failure meds we use. If we're not able to use those medications, or if a patient isn't tolerating them, they're developing low blood pressure or dizziness from those medications, that is very possibly a sign that the heart failure is getting worse. If they're having repeat hospitalizations for excess fluid and having difficulty managing the fluid, despite water pills, That's another sign. And then we also look at abnormalities on lab work, like abnormal kidney or liver function. I mentioned new arrhythmias, and then just worsening exercise tolerance, and that might just even be impairments in daily living and showering and doing chores around the house and gardening. If that's becoming harder and harder, that can also be a sign that the heart failure is just getting worse. And so when we take a history and we're seeing these patients, we review these events, we kind of review all of those details very carefully. We want to understand exactly how a patient is feeling, what they're experiencing day to day, and whether that's changing. And if we're suspicious that there might be progressive heart failure, there's two tests that we like to do that are objective in sort of assessing how well the heart is working with the rest of the body. And they also give us good prognostic information, like some information about survival from heart failure. One of those tests is called a cardiopulmonary exercise test, where a patient gets on a bike, they're wearing a mask that takes a bunch of measurements, and measures their respirations, their vitals. They go as hard as they can on the bike, and it gives us a lot of really good measurements and information about how well the heart's working with the rest of the body and kind of what stage the heart is at in terms of how advanced the heart failure is. The second test that I mentioned is a special type of catheterization where we measure the pressures in the heart and the pressures in the lungs, as well as how much blood the heart's actually able to circulate to determine if that's adequate, and whether those might be suggestive that there is advanced heart failure. There's certain parameters that we look at on those tests.
Okay, very important information. Thank you for sharing that, Dr. Gupta. Now I'd like to talk about some of the medications that are available for treatment. Turning to Dr. Sheikh, what are some of the common medicines or new medications that are available to treat heart failure, and how do they work?
Thank you so much for the question. In my introductory comments regarding risk factors, little did I realize when I was training as a physician that, attacking some of those risk factors, one of which I was a glaring omission in my initial comments, was actually the epidemic of obesity. And so what I think is very exciting in regard to the treatment for heart failure is we've never had a greater range of both medical and device therapies to support patients on their journey from the diagnosis of heart failure and the symptoms that they suffer from through a better quality of life. And broadly speaking, again, thinking about that bifurcation between those individuals who have heart failure with reduced ejection fraction and those who have preserved ejection fraction, there is increasing data regarding the benefits of 4 categories of drugs in patients with reduced ejection fraction. Those where the ejection fraction is less than technically 50%, though the entirety of the data is really those with an ejection fraction less than 40%. And broadly speaking, those 4 categories in no particular order are beta blockers, particularly the FDA-approved treatment carvedilol, otherwise known as Coreg, metoprolol succinate, or bisoprolol. Those are 3 FDA-approved beta blockers for the treatment of heart failure. A second category, which has really been revolutionized in more recent years, is a category where there's one of the 3 drugs employed, an ACE inhibitor, classically lisinopril or enalapril, that's now been supplanted by the more recent drug sacubitril valsartan, whose trade name is Entresto. And I think, though I tend not to try to use trade names, I think our audience needs to know them because they see them on television every day. And so it's important for them to recognize those names. That drug, which is a combination of 2 pills, sacubitril and valsartan. Valsartan is in that same category as an ARB, has been shown to have improved outcomes for patients, survival benefit, quality of life benefit, functional capacity benefit, reduction in heart failure hospitalization for patients who receive those therapies when compared to a prior generation ACE inhibitor drug. Then the third category of drugs, which is, in my opinion, truly revolutionized the field, is a category of drugs called SGLT2 inhibitors. The 2 drugs that our audience have heard of are empagliflozin and dapagliflozin. These drugs are known as Jardiance, Farxiga are the trade names. And what is incredible about this category of drugs is that irrespective where you are in the spectrum of heart failure, preserved ejection fraction, reduced ejection fraction, there's a benefit for patients. And this is in the most recent sort of iteration, the real revolution in the category of therapy. All patients with heart failure, even at risk for heart failure, seem to derive a benefit from this category of drugs. So great benefit. And then last but certainly not least are MRAs. MRAs, mineralocorticoid receptor antagonists, come in two flavors, spironolactone and eplerenone. And these, either one of these drugs have great benefits. So when employed as a quadruple therapy for patients with reduced ejection fraction, survival benefit is enormous. Depending on the scoring you look at, it's years, and some studies maybe even more than a decade of improved survival. But the most important thing is, and our patients ask us all the time, I want to improve my quality of life. I can't think about survival. It's hard to think on a day-to-day basis about survival. But remember, your quality of life improves with these drugs as well. Your functional capacity improves. So that's really important. In the heart failure preserved ejection fraction category, because so many patients with that disease state suffer from obesity, beyond the therapies I've just highlighted, there is, for patients particularly who suffer from diabetes, a whole new revolution that we have learned about in the GLP-1 receptor agonist therapies. Those drugs, Ozempic and Zepbound and others that whose names go beyond the scope of today's discussion, which again, in the right patient population, are very beneficial. Now, in the second question you asked regarding lifestyle modification, I believe you asked that question as well. There is a huge opportunity for improvement there as well, because you're sort of indirectly and directly improving the risk factors for the disease you develop. So if we exercise regularly, patients' quality of life and their self-perception of their quality of life measured by objective criteria improves. People feel better. They are more likely to be hopeful about their outcome, more likely to feel that they're on the right trajectory. And this, coupled with established therapies for patients with reduced ejection fraction, heart failure, cardiac rehabilitation, has been shown to improve the outcome. Again, reduce the risk of heart failure hospitalization, improve functional capacity, improve quality of life. Now, again, if we address obesity or we address other risk factors, patients will garner a benefit. There are some individuals who we don't know, they might have a genetic predisposition, who may be seemingly drinking, what seems to be mild amounts of alcohol, but that alcohol may actually have a deleterious effect, more pronounced in individuals who already have a predisposition to the disease. And so that's an important discussion for you to have with your doctors, because when we review the systems of our patients, we ask the questions as to what puts you at risk. We ask questions about family history, and our doctors and our clinicians should be asking that question, because if we find out a number of family members have heart failure or symptoms suggestive of heart failure, we might actually consider employing genetic testing to understand what your risk profile looks like.
All very important information. Thanks for talking about the lifestyle modifications as well. One other question for you, Dr. Sheikh. What are the indications that treatment modifications are needed? Oh, you're muted. Sorry.
Don't know how I did that. Sorry, my apologies. Thank you. That's such a good question. Too often we, through no fault of the clinicians or patients, we achieve a steady state and we say, oh my God, you feel better. Great. Our work is done. But sadly, our work is not done. We have to readdress, and you heard Dr. Gupta's comments regarding, the pursuit of objective testing to ask ourselves, where am I in the disease? Is the disease under our own noses progressing? And if it is, what are we going to do? The one basic adage is, it's not a binary approach. By that, I mean, just because you started a beta blocker doesn't mean the work is done. The data says we should try to achieve the highest, the maximum dose for each category of drugs in hopes of getting the best outcome. Now, the good news is in two of those categories of drugs, the SGLT2 inhibitors and the MRA, it actually is binary, meaning usually you just start the drug at one dose, particularly in the Jardiance and Farxiga category, where it's 10 milligrams a day. There's no dose adjustment needed. Yes or no, you take it, you monitor the patient. And similarly, in the MRA category, the eplerenone or spironolactone, it's 25 milligrams a day. But for the beta blocker, for the Entresto or ACE inhibitor ARB, we really want to achieve maximum doses, which are defined by those doses that were used in clinical trials to achieve the best outcome. Now, our patients may not be able to achieve that, and that's okay. But then what we need to do with our clinicians is to ensure, based on the parameters that Dr. Gupta gave us, as to how we might be on the lookout for the disease to progress. So functional capacity assessment, looking at kidney and liver function, obviously learning from our patients how they're feeling, and again, living a very healthy lifestyle.
Thank you very much for explaining that, Dr. Sheikh. At this time, I want to address our viewers. Thank you so much for tuning in, everyone. We're talking all about heart failure and advanced heart failure. We're joined today by some of our advanced heart failure cardiologists. We have Dr. Sandeep Jani, Dr. Richa Gupta, and Dr. Farouk Sheikh. It's critically important for patients, caregivers, anyone interested in improving heart health to understand the risk factors, symptoms, and treatment options that are available for heart failure and advanced heart failure. We have more to discuss, so keep watching. Share this with your friends on social and give us a like to let us know that you're here and that you're watching. We have a few more questions. So I want to turn it over to Dr. Johnny. Can you share why is it important to see an advanced heart failure specialist?
Yeah, sure. Thank you. First of all, let me just say that heart failure is a scary term. And I think it's a term that Dr. Sheikh, Dr. Gupta, and myself, and basically everyone else who does this would like to change, but it's a historical relic, so it is what it is. And I think being told that you need to go see an advanced heart failure doctor is a scary thing for that reason. And, if you look us up on the internet and you read our bios and the patients we deal with, I think it can be very scary to be like, oh my God, I have to go see Dr. Johnny. But let me reassure you that Dr. Gupta and Dr. Sheikh are very nice people. And I think I'm a nice person as well. And I feel like most of my patients leave the office more reassured than they are scared. So it's not a scary experience. But what we do really well as advanced heart failure doctors is some of the stuff that Dr. Gupta alluded to before. We understand the subtleties of heart failure, and when heart failure that's relatively low risk starts to become higher risk, and where the heart is starting to really struggle. And we do that, with various tests, including the cardiopulmonary stress test that Dr. Gupta mentioned, and heart catheterizations. And then we have large infrastructures to kind of deal with the medications. And for the small group of people who need more aggressive therapies, we have infrastructures to plug them in and to figure that out. So let me say, usually what happens when someone comes and sees me is I ask the first question, which is, why is your heart the way it is? And then I go about doing all the diagnostics I need to do to try and understand that. And if there's anything fixable, we go fix it. If it's a valve that's a problem, we fix the valve. If it's, that you need different medicines than you're on now, we go down that pathway and fix all the medicines. We figure out if the heart failure is, relatively low risk and that you'll be fine for a long time, and we have you on good medicines and things will be okay. And we just follow every once in a while. Or if you're sort of on the higher risk platform in which we need to pay closer attention. And so we sort of tackle all those issues all at once. And at the same time, we get rid of all the fluid you got. So if you got excess fluid that's making you feel poorly, we are very aggressive about getting rid of all the excess fluid. We want you at a normal amount of fluid in your body. And that makes the heart most efficient. It makes you feel the best and gives your heart the best chance of doing well in the long term. In addition to that, we make sure that all the appropriate devices have been deployed at the appropriate time. So the things like pacemakers and defibrillators and all the other devices we have nowadays to deal with valves and everything else, we try to navigate all these things. Seeing an advanced heart failure doctor is generally not a once in a lifetime visit. Generally, it's a journey, and it'll take weeks or months or sometimes years to get all these things squared away and to assess things. But that's sort of where we excel, I think, is in understanding the subtleties of the disease and risk stratifying and fixing all the things we can fix.
It's a hopeful message, Dr. Johnny. Thank you very much for that. One other question for you. How often do patients need to see their physician to ensure that their heart failure is under control?
Yeah, it's a really good question. And some of it depends on what kind of heart failure you have and how severe it is. So early on, you'll probably see us a fair bit. And that may be monthly or maybe every couple of months or every third month, or sometimes even more frequently than that, depending on how you're doing at the time. If if your heart failure is relatively stable at that point and you're in kind of the lower risk category, people may stretch out. And if we still have work to do, medications to adjust, testing to sort out, understanding to be had, might still be frequent. It just sort of depends on where you are in the spectrum.
All right, thank you, Dr. Johnny. Turning to Dr. Gupta now, can you share a little bit more about the various monitoring devices and how they work?
Yeah, I could talk about this for a long time, but I'll try to be succinct. There's a lot of new technology and just an explosion of devices that have been developed really in the last 5 years that are being used at pretty much every big cardiology heart failure program. These are devices that are beyond, the traditional devices that you hear about, like defibrillators and pacemakers. These devices specifically, we have good data to show that some of them can help us increase survival, reduce heart failure hospitalization, and also importantly, improve quality of life, which is really, really, really important for patients. I think to be able to, do ADLs, that's activities of daily living, to just, not feel short of breath all of the time, to increase their ability to walk more, exercise more. These devices, I just want to put out one caveat, is that they work really well when the heart failure is not too advanced. But they're really good devices that we can pull out of our toolbox when, let's say, medications aren't improving quality of life, or aren't helping keep the fluid down and keeping patients out of the hospital, which staying out of the hospital is also a huge win for quality of life, in my opinion. And so it's really kind of in that area between after medications have started, if patients are still symptomatic and could have better quality of life, or are still dealing with things like extra fluid and feel limited because of their heart failure, but aren't sick enough to the point that they need something like a surgical therapy, a surgery for their heart, like heart transplant or left ventricular assist device, which those are things we're going to talk about next. So I'm not going to jump into that. So in the guidelines currently and FDA approved, there's a device called the CardioMEMS device, which you probably, many patients probably have seen commercials for this, which is a sensor that gets implanted into the pulmonary artery, and it's put in non-invasively, so just percutaneously goes in through, the vein in the neck. That sensor allows us, in the heart failure clinic to track exactly how much fluid a patient has on board. So every patient who gets this device gets a pillow that they basically lay down on, and it transmits the pressures in the heart. And so it tells us, whether there's fluid building up well in advance of a patient having worsening shortness of breath, weight gain, or some of the symptoms we see with excess fluid. And so allows us to basically prevent that patient from, needing to go to the hospital for a heart failure hospitalization. And there's been good kind of randomized controlled trials that show reduction in heart failure hospitalization, and also actually a signal for improvement of survival when they combine all of the trials that have been done and kind of look at that outcome specifically in patients who have an ejection fraction less than 35%. So that's one good device that we use. The other things that we pay attention to also are whether there are valvular problems contributing to heart failure. So for instance, as heart failure progresses, the ventricle, the left ventricle, which is the main pumping chamber of the heart, can become stretched. And the mitral valve can also become stretched and leak, which causes kind of backflow of blood into the lungs and creates shortness of breath. If that leaking becomes severe, we have devices that we can use that actually plug up that leaking. And those devices also increase survival, greatly improve quality of life, reduce heart failure hospitalization. So that's something that we also kind of pay attention to when we're evaluating a heart failure patient, is whether a patient might benefit from something like that. And that's called a MitraClip device. And then there's another category of devices that have not yet made it into the heart failure guidelines, but received FDA approval back in 2019 and have been started to become more common and being used more. These are devices that are aimed at improving quality of life, exercise capacity, functional capacity in heart failure patients who still remain symptomatic despite GDMT. There's two kind of big devices right now in the market. One is called the Barostim device, or baroreflex activation therapy is the non-device name to that therapy. And the second one is called cardiac contractility modulation, or the optimizer device. I'm happy to go into those quickly if we have time. Okay, so let me start with the Barostim device. I think there's kind of an easy way to understand what that does. Barostim is a carotid sinus stimulator device. It basically looks exactly like an ICD. I wish I had a picture that I could hold up to show you, but there's a generator that is placed subcutaneously right underneath the chest. That is hooked up to a lead that's tunneled up to this bundle of nerves right up here where the carotid sinus is, so right over the carotid artery. By stimulating the carotid sinus, this device basically allows for the nerve that's up here to send signals to tell the heart to relax. Heart failure is basically, in sum, is the dysregulation of the nervous system and the nerves that are create stress hormones. So the medications that we use to treat heart failure all combat those stress hormones that are detrimental to heart function with time. So in effect, the Barostim device is kind of acting in a similar way to the heart failure medications, but doing it in a mechanical way by actually kind of activating the nerve that allows for those stress hormones to be decreased and to prevent heart failure symptoms. So there was a trial that was done a couple of years ago called the BEAT-HF trial. It was randomized and showed that patients who got the device experienced greater improvements in quality of life. They were able to walk farther without shortness of breath and had increased functional capacity. The second device is the cardiac contractility modulation device, the optimizer device. This, unlike the Barostim, is a device that actually goes into the heart. So similar to Barostim, there's a generator, but there are leads that go into the right side of the heart, similar to a pacemaker or ICD. And those leads create electrical impulses on and kind of activate the heart to better allow the heart to have improved kind of energetics and calcium handling. Basically, what that translates into is kind of increased contractility, hence the name contractility modulation. And so that increased contractility in the heart that it's delivering was studied also in a randomized controlled trial. And those patients who got the device compared to those that didn't receive it had similar improvements in all of those same quality of life endpoints. Functional class, exercise capacity, and then just reported better quality of life afterward. Those trials were not powered to look at survival or heart failure hospitalization. So we don't have data for those devices specifically. The Barostim device is right now FDA approved for patients with an EF less than 35%. So that's a requirement. The cardiac contractility modulation is for those with ejection fraction between 25 and 45%. But I don't think the audience should necessarily worry about that kind of thing or those specifics. A heart failure doctor will know kind of which device might be best for which patient depending on what's going on.
Thank you very much, Dr. Gupta. Good to know that there are devices that can help depending on the different stages of heart failure. So thank you very much for giving us that information. Turning over to Dr. Johnny now. On the heart failure spectrum, when is surgery indicated for a heart failure patient?
So it's a really good question. And so there's different levels of surgery, right? There's things that Dr. Gupta and Dr. Sheikh and I would call procedures, which are kind of minor, what we consider to be relatively minor. And then there's minor surgeries, and then there's big surgeries. And so surgery often happens, early on after diagnosis, one type of surgery or other. And some of that is heart catheterizations to try to understand the cause of the heart failure and look at the blood supply to the heart arteries, and understand the pressures in the heart and how much blood the heart is pumping, things like that. And sometimes if people have, you know, bad heart artery blockages, people will need bypass surgery early on. In people with kind of don't need bypass surgery, then, the next decision point is often after we've started medications and we see how the heart does. And we start thinking about, do people need pacemakers or defibrillators, or some of the devices that Dr. Gupta just talked about? Do they need valve interventions? And so that's usually a few months, sometimes longer down the line, after someone is diagnosed. And then there are the people whose hearts have entered this stage D sort of level, where the medications and all the other stuff we've done is no longer really doing the job. And we have to start thinking about things like heart transplants and implantable heart pumps called ventricular assist devices. And that can happen, for most heart failure patients, that will never happen. But for the ones who need it, that can happen usually down the line from after diagnosis, though there's a very small cohort of people who are diagnosed upfront and need these things very quickly. So it really can happen at any point after someone is diagnosed, in terms of which surgery and what type of procedures and what needs to happen. It sort of just depends on where the person is in their trajectory at that point.
Okay, and I think you led to my next few questions about the LVAD. Could you share what that is? How does it work?
Sure. So an LVAD, a left ventricular assist device. So the left ventricle is the main pumping chamber of the heart to the body. And oftentimes in heart failure, that is the primary chamber that's failing. And so an LVAD is an implantable heart pump. It's a mechanical pump that goes inside someone's chest. And in fact, part of it goes inside someone's left ventricle. And it sucks blood from the left ventricle and injects it into the aorta, which is where your heart would inject blood to your body anyway. And so it takes over some or all of the pumping function of the heart. And it is a mechanical pump, so it runs 24 hours a day, and it runs on electricity. And so people have a small power cord called a drive line that usually is tunneled through the body and comes out of the abdomen on one side or the other, which plugs into a small computer called the controller, which is a little bigger than an iPhone or a cell phone. And that can plug into a couple of batteries that can last for hours and hours. Also, if someone's at home or sleeping or something, they have a long power cord they can plug in to the wall. And the LVAD, therefore, takes over some of the pumping function of the heart and works very well nowadays.
Awesome. I have a two-parter for you, Dr. Johnny. At what point does someone need an LVAD? And also, the LVAD has been described as the bridge to transplant or destination therapy. Can you explain what that means?
Sure. So we start thinking about LVADs and transplants when the heart is not able to keep up with the demands of the body any longer. And that is usually in a sense that it's not pumping enough blood to the other organs, and the other organs we worry about failing. And so we used to use these terms more commonly, bridge to transplant for an LVAD, which means that we put in an LVAD up front when someone cannot get a heart transplant up front. Or destination therapy, which is where someone cannot get a heart transplant for a number of reasons, potentially, and they are, the LVAD is the life-saving option for them. These sort of terms have gone away a little bit, and we think about, can someone get a heart transplant? Can someone get an LVAD? Can someone get both? Which one? What's the risk profile of which procedure and which surgery, and what will fit the risk as well as the patient's lifestyle and desires and goals and everything else. And then we, along with a huge team of people that you don't see on the screen here, social workers, therapists, nutritionists, surgeons, financial folks, all kinds of people, sort of put our heads together with the patient to try to figure out what's the right approach. And that might be an LVAD, that might be a transplant, that might be an LVAD first and transplant down the line, that might be neither. It just sort of depends on the situation at the time.
And then if you have an LVAD, does that automatically mean that down the line you'll need a transplant? And at what point is a heart transplant indicated as that treatment for the patient?
So if you're in advanced heart failure, stage D heart failure, and we're thinking about LVADs and transplants, we're thinking about both at the same time usually. And so it depends on the situation. Some people will get an LVAD and keep an LVAD and not get a heart transplant for various reasons, or things will come up that will make it not doable to get a heart transplant. Some people may be too old to get a heart transplant or have other comorbidities to get a heart transplant, and may live on their LVAD for years and years. And some people may have something up front that means that we have to do an LVAD up front, but that issue goes away over the course of time, and then we think about a transplant down the line. Or the LVAD some years from now starts to have issues, and then we start thinking about transplants at that point. There's so many different avenues that can come up that make one likely or not likely at any given time, really.
Thank you very much, Dr. Johnny. Now I want to talk a little bit more about the heart transplantation process. Turning to Dr. Sheikh, are there any barriers to heart transplantation?
Thank you for the question. The most obvious barrier is the relative paucity of heart available for those individuals who need a heart transplant. So in your introductory comments, you highlighted that we still sit here today, years into this field, not with true definitive epidemiologic data to say how many patients progress to an advanced form of heart failure which requires a heart transplant or a left ventricular assist device. We have estimates, like you said, roughly 10%, maybe 5 to 10%. But when we think about the option of cardiac transplantation, we should unfortunately be sobered by the reality that only roughly 4,000 heart transplants are performed in the United States per year. And this is juxtaposed to estimates of 10,000 Americans who might need a heart transplant. So there are people who are placed on a national waiting list for transplant. Each center, including MedStar Health, that performs heart transplantation, places their patients on a list for heart transplant, and those patients are waiting with other patients throughout the region and the country awaiting a heart transplant. So this is unfortunately one of the realities we face. Now, there's some exciting things happening in society to increase the number of organs involved. There's some incredible medical technological advancements to allow for us to transport hearts from greater, longer distances than ever realized previously. And then obviously all of us can ourselves contribute to society by being organ donors if we choose to do so, and if it's reasonable based on our personal beliefs. So that I think is the first limitation. I apologize, I forgot the totality of your question. Remind me.
I think that was it. It's just any barriers to the heart transplantation process. Yeah.
I think the other barriers are and this is the hardest conversation I personally have with patients. I think I can speak for any heart failure doctor in the world, and any physician. We wake up in the morning early and we go to bed late only to improve the quality of the lives of our patients, to serve as stewards, to serve our patients, to improve their lives. And the reality is sometimes we have to have the difficult conversation with patients that we do not believe they would derive benefit from a certain treatment because some aspects of their physical status, their personal status, etc. And some of those examples include obesity, so meaning as measured broadly by body mass index, which is one measurement of obesity. There's data that if that BMI is above a certain number, usually typically well above 40, the outcomes are not as good for individuals who receive a heart transplant. In fact, the chance of survival decrease. Certainly, I know of no program in the United States and the world that would offer a heart transplant to a patient who is actively smoking, right? And that's not because we're being prejudicial, but rather when one receives a heart transplant, the act of smoking has been shown beyond a shadow of a doubt to be very harmful to individuals who smoke, meaning the arteries of that transplanted heart acutely become diseased and reduce the blood flow to that transplanted heart, and the heart will not survive. So these are examples where there may be other aspects of why we might not be able to offer that type of treatment. It's a complicated treatment. I think there is this, appropriately so, it's the gift of life. There is this sort of mythologic status for transplant, but it requires lots of interface with clinicians. It takes a time to get a heart transplant, meaning you have to stay in the ICU or in the hospital waiting for a heart transplant. There are a lot of personal and family-related sacrifices related to that. And that's, again, not to dissuade people from pursuing it. It's just that we are very transparent, both here at MedStar Health and throughout the field, in terms of understanding what is needed to derive the benefit from therapy and from the treatment. And that's, I think, along the lines of what Dr. Johnny just made in regard to the team approach. Transplant coordinators, social workers, pharmacists, surgical experts, medical experts like Dr. Gupta and Dr. Johnny. So it takes a team to be able to do this.
Teamwork makes the dream work. That's what we've always said around
I like
here. That's good to know. Also, Dr. Shea, could you share a little bit more about the surgical advances? You mentioned this a little bit in your response to the previous question. Any surgical advances on the horizon for heart failure patients?
I think that the biggest excitement for me in this field is for our audience, for our patients, our families. The one thing I would say is heart failure team members have never been more aligned with our surgical partners, meaning you can't have a heart failure program unless you're sitting like right outside my door. The office right across from me is one of our surgical partners. 2 doors down the hallway is another surgical partner. By this, I mean, when we're caring comprehensively for our patients, I mean it as the highest compliment that in cardiovascular medicine, heart failure doctors are like the primary care doctors of the field. We are thinking in totality, not just about your heart. We're thinking about how you are psychologically doing. How are your kidneys doing? Is your diabetes well controlled? And so from that same approach, our surgical team members have to be involved because sometimes, as Dr. Gupta was mentioning, there's a leakiness of a valve, and maybe as opposed to a device, a surgical therapy might be better. Or there may be some arrhythmia, some electrical disturbance of the heart that make us think, what, the prognosis is maybe not as good as we thought. Maybe we need to start thinking about a heart transplant sooner rather than later. So these are one very tangible way in which we interface with our team partners and the surgical partners. All that being said, incredible, revolutionary advances in cardiac transplantation, again, to be able to have more hearts available for our patients through preservation strategies, organ procurement strategies. Additionally, in the LVAD space, there's going to be even more disruption. What's going to happen is what many of our patients turn us down for LVAD therapy because they don't love the idea of being attached to a computer and a drive line, even though those batteries last 12 and 14 hours. Well, very soon, the company that makes this therapy is going to create a technology where you don't have to be connected to that computer, where you can be detached for up to 6 hours. That's not science fiction. That's actually coming relatively soon. And we're not talking about fully implantable devices, which are on the horizon. I don't have a date for you yet. They're probably a few years away, but they're on the horizon. There are other technological advances with other implantable devices from surgeons that are also on the horizon for rare forms of disease. But I would simply say that the American system, such where technology drives innovation, is strong and remains strong.
Great message. Also a hopeful message to know what's on the horizon. As we wrap up today, I want to open this last question up to the rest of the team here. Any last words for our viewers today? All right.
We've got two eloquent speakers. Someone's got to.
I just want to
I-
reiterate that, heart failure is a scary term, but it doesn't necessarily have to be scary. And, like Dr. Sheikh said, we get up early and we go to bed late trying to help our patients navigate, what's going on with their heart. And I think, a lot of us have sort of algorithms in our head as to how to approach these things. And so, this is something that is manageable, and with big teams like ours, it's something that we can navigate with you to kind of give you the best quality of life and the best, outcomes that we can.
We got to get Dr. Gupta get the last word. Can we do that?
No, I was going to say,
Yeah.
almost exactly the same thing, but, also that, I think there's this huge opportunity also for our audience, you all, the patients, to take your health, into your own hands. This is an era where I want, every patient to feel really empowered to, voice the things that are important to them. And that's also what is really important to us, is what's important to you. And it may be different from person to person. And, therapies are not prescriptive. We take into consideration, your entire life and everything that you've gone through, and, how you're feeling and what's important to you in the future. And that's very important to us when we're kind of helping guide what therapy would be best for you next.
Great message. Thank you all. That wraps up the time that we have for today. Thank you to Dr. Johnny, Dr. Gupta, Dr. Sheikh for joining us today and answering my questions. Thanks to all of you for tuning in. To learn more, you can visit our website. We're going to place that link for you to learn more in the comment section, and we will see you next time.
Thank you.
Thank you.
Thank you so
Thank
much.
you.
This was great.